present to you for an eye checkup. Therefore, we need to know what sign that we need to look for. And sometimes the presenting eye problem may be the first sign of the underlying systemic disease. So it is important for us to know more about these signs. So let's take a look at the anatomy of the sclera first. The sclerosoma composed of collagen bundles of varying size and shape that are not uniformly oriented as in the cornea. So they are not transparent. So here, the is continuous anteriorly to the cornea, making up the 5/6 of the outer coat, and then the cornea making up for 1/6 of the outer coat. And then the surface is covered with tendons capsule here, which is the facial shade of the eyeball. And the inner layer of the sclera, which is lamina fascia, will blend with the uveal tract, which is the choroid, ciliary body, and the iris. So let's take a look at the histology of sclera. Sclera consists of 3 layers, and the outermost layer is called episcleral tissue, which is a thin, densely vascularized layer of connective tissue overlying. It contains vessel and unmyelinated nerve fibers, bundle of collagen, and cells like fibroblasts, macrophages, and lymphocytes. And then the second layer will be the sclera proper, which is an avascular structure. It is composed of collagen bundles, elastic fibers, fibroblasts, and ground substance, such as which is proteoglycans and glycoproteins. The collagen bundles are varying in size and irregularly arranged in all directions. And the innermost layer of the sclera will be lamina fascia, which is brownish in color as there is abundance of melanocyte, mostly migrated from the choroid. And lamina fascia is separated from the choroid by a thin potential space known as suprachoroidal or perichoroidal space. The first topic today will be episcleritis, which is an immunologically mediated inflammation of episcleral tissue that lies between the conjunctiva and sclera, which is the first layer of the sclera. Okay, so episcleritis is a common, usually idiopathic and benign, recurrent and frequently bilateral condition. Female with a ratio of 3:1 in middle age, and it is rarely occur in children. It is self-limiting and tends to last it for a few days and up to 3 weeks, but rarely longer, and often will be recurrent. Episcleritis is due to the inflammatory response localized to the superficial episcleral vessel. This will cause vascular dilatation and produce the redness. And there is two types of episcleritis, which is a simple episcleritis and nodular episcleritis. So fatigue, but there is also other associated diseases, which we will be divided into two, ocular and systemic disorder. However, ocular is more common, where a patient have dry eyes, rosacea, or contact lens wear that will come with episcleritis. And there's also systemic disorder, which is such as collagen vascular disease, which is, for example, rheumatoid arthritis, Crohn's disease, ulcerative colitis, SLE, and ankylosing spondylitis. Then patient may have vasculitis, metabolic disease such as gout, and patient may have infections, which is, for example, like herpes zoster. Please. Clinical presentation for episcleritis. Firstly, we'll look at the simple episcleritis, which accounts for 75% of the cases. It has tendency to reoccur in 1 to 3 months, but it will decrease in frequency with time. The features often peak within 24 hours and will gradually fading over the next few days. So the symptoms of simple episcleritis will be redness and discomfort, but it is rarely painful, and grittiness, photophobia, and there will be no discharge and no blur of vision. Thus, the sign will show normal visual acuity, and there is no tenderness on palpation. It can be divided into two, which is sectorial and diffuse. Second type will be nodular episcleritis, which is less acute onset but more prolonged, and it is usually associated with systemic disease such as SLE or rheumatoid arthritis. The redness will last it longer than simple episcleritis, and it will enlarge. The nodule will be enlarged over the next 2 to 3 days with worsening of discomfort, and it is more painful than the simple episcleritis. There will be tender as a sign, and it is almost always in the interpalpebral fissure. The visual acuity will be normal, and during the slit line examination, there will be flat anterior scleral surface seen. This is just to differentiate between the episcleritis and scleritis, which in scleritis there will be a nodular surface during the slit line examination. And then the intraocular pressure occasionally will be increased, and after several episodes, there will be the inflamed vessel will be permanently dilated. So for the principle of management of episcleritis, we need to reduce the discomfort and the inflammation in the affected eyes. So usually, we will do the cold compression for the eye or drop like refrigerated artificial tears, but this is for simple episcleritis, as the other treatment is usually more indicated in the nodular episcleritis, which is topical steroid for 4 times daily up to 1 to 2 weeks. And topical NSAID can also be given as alternative because it is less effective compared to the topical steroid. And oral NSAIDs are typically in patient with a known systemic association. And then lastly, I will talk about the difference between episcleritis and so my friend will discuss more about the scleritis. So episcleritis is a idiopathic inflammation, while scleritis is autoimmune dysregulation. And in episcleritis, it is more sudden in onset or acute in onset, while scleritis is more gradual or subacute onset. Episcleritis will have discomfort or mild pain, redness, irritation, and photophobia, while in scleritis, it is very painful or patient will have severe pain and pain with eye movement, and then there will be blurred vision, photophobia. For the sign or during the physical examination, there will be mobile vessel in episcleritis, and it is inflammation of the no dilatation of the superficial episcleral vessel, while in scleritis there will be adherent vessel, and then in episcleritis it will be blanched with phenylephrine drops and reddish in hue, while in scleritis it does not blanch with phenylephrine drops. It means like if we put the phenylephrine drop, the redness does not disappear, while in episcleritis, the redness will disappear. And then it is more in bluish hue, and the slit lamp examination will reveal nodules, sclerotining, and corneal changes. And then patient will have systemic inflammation symptoms such as joint pain and rashes. So I'll pass the next presentation to Alia.
Assalamualaikum and good evening everyone. So today for my part I will present about the scleritis, uveitis and also endophthalmitis. So first we go for the scleritis first. Scleritis is diffuse or localized inflammation of sclera associated with the collagen vascular diseases. But scleritis is uncommon compared to episcleritis. So we move on to the etiology of the scleritis. So approximately 50% of the scleritis cases which tend to have several clinical causes are attributable to systemic autoimmune or rheumatic disease or are the result of immunologic processes associated with infection. So these are the common causes of the scleritis include rheumatoid arthritis, polymyositis, dermatomyositis, ankylosing spondylitis, spondylarthritis, vasculitis, redness granulomatosis, herpes zoster ophthalmicus, syphilis, and also gout. And the rare causes include tuberculosis, Lewis, borreliosis, and also Rett syndrome. Next slide, please. So this is the common clinical features of the scleritis. The symptoms include extremely painful red eye, which can awake patient during the night. And also patient will be presented with blurry vision and sometimes will have photophobia. The signs of the patient will have intense injection of the scleral and episcleral vessels. Other than that, patient will have lobe extremely may be tender and also scleral edema. As you can see in this picture, showing the scleritis, the sign and symptom of the scleritis. Next slide, please. So, scleritis is divided into two, which is immune-mediated scleritis and also infectious scleritis. For the immune-mediated scleritis, it is divided more into anterior and also posterior scleritis. For anterior, it is divided into non-necrotizing, necrotizing with inflammation, and also necrotizing without inflammation, or the other name is scleromalacia perforans. For the non-necrotizing, it is further divided into diffuse and also nodular. For necrotizing with inflammation, it is divided into three types, which is vaso-occlusive, granulomatous, and also surgically induced, which may be also be effective. And for the second classification of the scleritis is infectious scleritis. The main causes include herpes zoster, tuberculosis, leprosy, syphilis, Lyme disease, and also Pseudomonas aeruginosa. Next slide, please. So moving on to the non-necrotizing anterior scleritis. For this type of non-necrotizing, it is divided into two, which is diffuse and nodular. For diffuse, it is more common in female compared to male and usually presents in the fifth decade. Symptoms include ocular redness progressing a few days later to pain that may radiate to the face and also temple. The signs include vascular congestion and dilatation associated with the edema. The redness may be generalized or localized to one quadrant. The secondary features can include the chemosis, eyelid swelling, anterior uveitis, and also raise in intraocular pressure. As you can see in the bottom left picture, this is the diffuse type of non-necrotizing anterior scleritis. So for the nodular type, it is usually present in the fifth decade. The symptoms include the insidious onset of pain followed by increasing redness, tenderness of the globe, and the appearance of the scleral nodule. As you can see in bottom right of the picture, there's presence of the scleral nodule. And for the signs, include the scleral nodules may be single or multiple. A slit lamp beam show an elevated anterior scleral surface, and also multiple nodule may expand. Next slide, please. So for the necrotizing anterior scleritis, it is divided into inflammation with inflammation and also without inflammation, or the other name is scleromalacia performance. For with inflammation, the age of onset is average around 60 years old. The symptoms include gradual onset of pain that becomes severe and persistent and radiate to the temple, brow, or jaw. It frequently interferes with sleep and responds poorly to analgesia. The signs include, um, so we divided the necrotizing with inflammation into three types, include the vaso-occlusive, granulomatous, and also surgically induced scleritis based on the causes. For vaso-occlusive, it is associated with the rheumatoid arthritis. For granulomatous, it is associated with the granulomatosis or polyarthritis nodosa. And for the surgically induced scleritis, it is typically starts within 3 weeks of a procedure. For example, induced by any type of surgery, including strabismus repair and also trabeculectomy. For the necrotizing without inflammation, it is extremely rare and it is specific type of progressive scleral thinning without inflammation. The symptoms include mild non-specific irritation, pain usually absent, and also vision usually unaffected. The signs include necrotic scleral plaque near the limbus without vascular congestion. Next, please. So next type is posterior scleritis. Posterior scleritis is a potentially blinding condition in which diagnosis is commonly delayed with an adverse prognostic effect. The age of onset is often less than 40 years old, and the symptoms include pain, which does not correlate well with the severity of the inflammation, but tends to be more severe in those with accompanying orbital myositis. So the signs include usually patient we have bilateral symptom and in 35% of the patient, and the signs include choroidal folds are usually confined to the posterior pole and oriented horizontally. As you can see at the first picture, this is the example of the choroidal fold. Okay, and then second one, uveal effusion with choroidal detachment may be present. as you can see, the second picture is showing the uveal effusion. And then also in the posterior scleritis, we'll have this edema, myositis is very common and gives rise to diplopia, pain on eye movement, tenderness to touch, and redness around a muscle insertion. Other than that, patient will have proptosis, usually mild, and is frequently associated with ptosis. Occasional features include raise in intraocular pressure, periorbital edema, and also chemosis. Next slide, please. So this is the principal management of the scleritis. So I divide into two types, which is immune-mediated and also infectious scleritis. But we have to remember that scleritis is vision-threatening cases, so need urgent referral to ophthalmologist. So for the immune-mediated scleritis, first is we give topical NSAIDs to relieve symptoms and edema in non-necrotizing scleritis. Other than that, patient also in non-necrotizing scleritis can be given systemic NSAIDs, periocular steroid injection, systemic steroids, and for immunosuppressive agent, and also we can give immunosuppressive agent or biological blocker to unresponsive to NSAIDs, to patient with um, to patient who have unresponsive towards the NSAIDs, and also for the necrotizing type of the scleritis and posterior type of scleritis. Other than that, we also need to treat the underlying etiology, for example, rheumatoid arthritis and so on. For the infectious scleritis, we give specific antibiotics and also topical and systemic steroids may also be used to reduce the inflammatory reaction. Next slide, please. So moving on to next part, which is uveitis. Uveitis, as the name is, inflammation of the uveal tract, which include choroid, ciliary body, and also iris. So it is divided into four types, which is based on the anatomical location. The first one is anterior uveitis, which is the inflammation of the iris, accompanied by increased vascular permeability. As you can see in the first picture, at the bottom left of picture, which indicates the anterior uveitis. It only involves the part of iris. The second one is intermediate uveitis, which is include the inflammation of ciliary body, pars plana. Pars plana is a part of ciliary body, and also vitreous. For the posterior uveitis, it includes the inflammation of the posterior uvea and may involve the choroid, retina, or both. And last one is panuveitis, which the inflammatory changes affect the whole part of the uveal tract. Next slide, please. So this is the clinical feature of the uveitis. The symptoms include painful red eye, photophobic, blurry of vision, and also floaters. The signs include ciliary or circumcorneal injection, reduce in visual acuity, sluggish or irregular pupil due to reflex sphincter spasm. Iris details may be hazy due to inflammatory cells in aqueous. Tiny round opacities may be visible. Raised intraocular pressure and also cataract is seen in recurrent or chronic uveitis. Next slide, please. So for the anterior uveitis, it is the inflammatory cells may be visible, clumped together on the endothelium of the cornea, particularly inferiorly, or the other name is keratic precipitates. As you can see, the first picture is, sorry,
Can you
doctor.
show with the mouse?
Okay. Mm, Um, how? Wait.
Alia boleh request untuk annotate.
Kejap So, first is keratic precipitation in corneal endothelium. Is it here, doctor? You guys can see?
Mana? That is, this is the reflex. Slit lamp
Oh,
punya light reflex. Yang nampak hablu-hablu kat bawah tu, kat bahagian bawah tu, yang tiny dots.
is it here? Tiny dot.
Ah,
Okay. So that is the keratic precipitation in corneal endothelium. And then slit lamp examination will reveal aqueous cells and a flare due to exuded protein. And
jadi
also
kita tahu tapi you all tak boleh nampak sebab kita guna slit lamp untuk tengok cells ya. So torchlight memang tak nampak.
okay, next is the iris may adhere to the lens and bind down the pupil, or the other name is posterior synechiae,
Unit.
which is the second picture. Is it here, doctor? Apa tu?
Bukan tu, besar sangat tu.
Bukan.
The iris may adhere to the lens. So it's the one, the part of the iris which does not look round or smooth. Can you undo that? Because that line is already covering the synechiae.
Okay. Yeah.
Yang kat
Okay.
bawah tu, at
Okay.
5 and 6
Sorry,
o'clock,
doctor.
nampak tak?
6 o'clock. Here.
5 and 6 o'clock dekat pupillary margin.
Pupillary. Here.
You see the pupil is round and smooth, starting from 4 o'clock sampai ke 7 o'clock. Betul?
Yes.
Alright, and this part from 4 o'clock sampai 7 o'clock tu dia jagged. Dia tak smooth round dah. So this is where the pupillary margin is attached to the anterior capsule of the lens. Okay? Dia tak
Okay,
round dah,
doctor.
sebab dia melekat dah. This pupil is actually dilated, being dilated. Okay? So kalau tak dilate, dia actually small, smaller than this. So when you dilate, so the parts yang attached to the lens, anterior capsule, will be anchored kat sini. That's why you see this 5 and 6 o'clock punya irregular is no longer round. Sebab yang the rest of the pupil dah dilated. Okay? From 4 to 7 o'clock ni dah dilated.
Okay. Okay,
Boleh,
doctor.
boleh
Thank you,
boleh
doctor.
tutup dulu.
Okay. So next is for hypopion. Hypopion is the inflammation. Which
Can you
is
see my
the
mouse?
wait.
Tak ada eh? Can you see my mouse? My mouse is
Okay.
pointing at the 5 and 6 o'clock.
Yes.
Nampak?
Uh-uh.
Yang ni yang posterior synechiae. These two. Dia melekat dekat anterior capsule of the lens. Okay? So how do I take over? Please take over the mouse. Take over the presentation.
Okay.
Alright.
Okay. Next is for the hypopion. The last picture is showing hypopion, which is hypopion is the white cells collected
White
to
apa?
form a fluid.
White apa?
White cells which collected to form a fluid level inferiorly, which is located.
Mana?
Is it here? Oh, sekejap. Alamak. Atas sikit.
You see that fluid level tu? Ada fluid level yang white tu?
Yes.
That is hypopion.
Okay.
Okay?
Okay, doctor. And also, in anterior uveitis, the vessels on the iris may be dilated and intraocular pressure may be elevated. Okay. So, this is for intermediate and posterior uveitis. The usually intermediate and posterior uveitis has the presence of cells in the vitreous. As you can see here, the vitreous cells, which I already labeled here, and there may be retinal or choroidal foci of inflammation, and also macular edema may be present. And also there is some snowbank formation and also snowballs formation in the intermediate and also posterior uveitis. Okay, next slide please. So for the principle of management of uveitis, first of all, we have to investigate and treat the underlying causes.
And very
Um,
important, number one, investigate and treat the underlying cause. Because the mainstay of uveitis treatment is steroid. Because we want to control the inflammation. So, and if your slide previously has listed the causes of uveitis, ada ke
Ada?
tadi?
Wait. Oh, sorry doktor, tak ada. Sorry, for uveitis, I tak letak.
So if you open your book and you see what are the causes of uveitis, there are so many. Okay, lambat-lambat, and you don't know how to identify what is the cause. It all depends on your history and your physical examination. So basically dia ada dua cause, infectious and non-infectious. Ada satu lagi immuno underlying immunosuppression conditions, immunosuppressed conditions. So yang penting ialah kita identify and investigate to identify the underlying cause. Kalaulah underlying cause tu infectious, okay, when you start steroid, apa akan jadi? Makin teruk ke makin elok?
Makin teruk.
Makin teruk. That's why you need to treat. Give antibacterial ke, whatever, and what is the cause? And then when you have started your antibacterial, then only you can start your steroid. Kalau you tak investigate and the cause is infectious and you tak treat that infectious cause, instead you control the inflammation through steroid, it won't resolve. Okay, the thing won't, because you are not treating the cause, you're just controlling the inflammation. Okay, go on.
Okay, doctor. So, next is steroid therapy. For anterior, we give topical or systemic steroid. For intermediate and posterior is same, which we use subtenon or intravitreal or systemic. Subtenon is an injection into the ocular road. And then next is cycloplegic agents, usually administered to the anterior uveitis. It is to reduce the cycloplegic spasm and provides comfort to the patient. Other than that, we can give analgesia to relieve the pain, antimicrobial if infectious cause, and also laser photocoagulation to snowbank formation in the intermediate and also posterior uveitis. Next slide, please. So this is the last part, which is endophthalmitis. And endophthalmitis is an inflammatory condition of the intraocular cavities, which is include the aqueous and also vitreous humor, and usually caused by the infection. Next slide. So for the etiology, the vitreous body consists of only a few cellular elements, which is hyalocytes. The inflammation of the vitreous body is only possible when the inflammatory cells can can gain access to the vitreous chamber from the uveal tract or retinal blood vessel. This may occur via one of the following mechanisms, include first microbial pathogens, and second one is inflammatory microbial or autoimmune in structure adjacent to the vitreous body. So for the microbial pathogen, bacterial inflammation is more common than the viral and also fungal. Example of the bacteria include the Staphylococcus aureus and also Streptococcus pneumonia. Fungi include Candida and also Cephalosporium, or virus include Epstein-Barr virus, HIV, and also cytomegalovirus, which enter the vitreous chamber either through direct contamination, for example, via penetrating trauma or incisive intraocular surgery, or metastatically as a result of sepsis. The virulence of the pathogens and the patient's immune status determine whether an acute, subacute, or chronic inflammation will develop. So, next slide, please. So, this is the common clinical picture of the endophthalmitis. The symptoms include painful red eye, and the discharge usually mucopurulent, and patient will have poor vision at day 3 to day 5. For the signs, which include red eye with hazy cornea and also relative apparent papillary defect, RAPD test positive, which indicates the serious visual damage to the patient. Last slide, please. So this is the principle of management. We have to know that the endophthalmitis is the urgent in patient. We have to treat the patient urgently. So first, it requires aqueous and vitreous sample for microscopy, culture, and sensitivity to know what is the causes behind the endophthalmitis. And then we give intensive topical broad spectrum antibiotics. Vitrectomy may be needed for virulent organism, and for Candida endophthalmitis, we give oral fluconazole. For mycotic endophthalmitis, usually we give amphotericin B and also cetone. So that's all from me. Thank you.
Okay, good afternoon,
Untuk slide ni saya
everyone.
tak nak bincang pasal medical information. I just want
Okay,
you
okay,
to present the ocular manifestations of each conditions.
okay, doctor. So I'll now continue the presentation with autoimmune diseases and their ocular manifestation. Next slide. First one is rheumatoid arthritis. A brief introduction. We know that rheumatoid arthritis is a chronic progressive autoimmune disease that causes
Skip
inflammation of the
because
joint.
hello,
Yes, doctor.
can we skip this part because this is already learned in your
Yes,
in your medical posting,
yes,
right? Or in your
yes,
orthopedic,
doctor.
right? Can we move on to the ocular manifestations of rheumatoid arthritis?
Yeah, this is the one. Okay. So, 25% of patients with rheumatoid arthritis will have ocular manifestations and such as keratoconjunctivitis sicca, episcleritis, scleritis, and keratitis. So we've heard of episcleritis and scleritis just now. So I'll talk about keratoconjunctivitis sicca and keratitis. Keratoconjunctivitis sicca is also can be defined as dryness of the conjunctiva, and it is the most common ophthalmic manifestation of rheumatoid arthritis. So it's because there's too little tear is being produced, or the tear that's been produced evaporates too quickly, so which makes the eye become irritated and sensitive to light. So that is why patients with keratoconjunctivitis sicca will be presented with dryness, foreign body sensation, burning, or photophobia. So usually artificial tears and punctum plugs can help relieve the symptoms. As for keratitis, there are several forms of keratitis such as stromal keratitis, sclerosing keratitis, keratolysis, marginal furrowing or guttering, or peripheral ulcerative keratitis, PUK, and this PUK is the most common type of keratitis in rheumatoid arthritis. So, peripheral ulcerative keratitis is also known as peripheral corneal ulceration or thinning, and it is very common in advanced rheumatoid arthritis. PUK occurs when immune complexes activates the complement system, resulting in chemotaxis of the inflammatory cells such as neutrophils and macrophages. So our neutrophils and macrophages, they release collagenase and protease that will destroy the corneal stroma. So, next slide. So, okay. If you see in the picture, picture B is that you can see there's a that is an early peripheral ulcerative keratitis, and you can see there's a crystanteric ulceration like a moon-shaped ulceration with an epithelial defect. And in picture C, that is the advanced disease resulting in contact lens cornea. And the last picture is how a rheumatoid paracentral ulcerative keratitis looks like. Next. Next slide. Hello, can you all hear me?
Yeah, on the graft disease, right?
Hello, can you all hear me? Okay, dah.
Yes.
Okay, all right, thank you. Next is Graves' disease. So we've learned that Graves' disease is an autoimmune disorder that causes hypothyroidism or overactive thyroid. So the ocular manifestation in Graves' disease is called Graves' orbitopathy, or it's also known as Graves' ophthalmopathy or thyroid eye disease. So the characteristic signs of Graves' orbitopathy is proptosis or exophthalmos, tearing, periorbital edema. The major ocular symptoms that patient comes with are foreign object sensation in the eyes, excessive tearing that is worsened by exposure to cold air, wind, or bright lights, eye or retroocular discomfort or pain, blurring of vision, diplopia, color vision desaturation, or loss of vision in severe cases. Next. So the pathogenesis of how there's ocular manifestation in Graves' disease is lymphocytic infiltration occurs in the orbital tissue, which causes the release of cytokines from the CD4 T cells. So these cytokines, they'll stimulate the orbital fibroblasts to produce mucopolysaccharides. So when there's too much of mucopolysaccharides, it causes tissue edema in the extraocular muscle. So the picture below is how Graves' orbitopathy looks like. As we can see, there's proptosis, which means bulging of the eyeballs, upper and lower eyelid retraction, periorbital edema as shown in the below the lower eyelid of the left eye, uh, of the right eye, and also brow fat compartment enlargement that is seen on both eyes. Next slide. Okay, next is ankylosing spondylitis. Ankylosing spondylitis is an inflammatory disease that affects the axial skeleton. So, like if it affects the spine, it causes the bones of the spine to fuse, making it less flexible and resulting in a hunched posture. So, if it affects the ribs, it can be difficult to breathe, and it commonly affects
Can we skip
males
this?
and most. Yes. Next slide. Okay, so the ocular manifestation seen in ankylosing spondylitis is acute anterior uveitis, which is the most common ocular association in ankylosing spondylitis. So usually either eye is frequently associated at different times, but for both eyes to get involved at the same time is quite rare. So usually patients who are HLA-B27 positive tend to have worse disease across a range of parameters, including earlier onset and greater intensity of inflammation with an increased frequency of complication. So besides acute anterior uveitis, other ocular features that a person with ankylosing spondylitis might have includes scleritis, episcleritis, and keratitis. Next. Okay, then sarcoidosis is a disease characterized by growth of granulomas in any part of the body. So usually the lungs and the lymph nodes are mostly involved, but they can also affect other organ systems such as the eyes, skin, heart. So for the most common manifestation of the eye is granulomatous anterior uveitis. And to diagnose an intraocular sarcoidosis, there's 7 key signs that we have to look for. The first one is mutton fat keratic precipitates. Like if you can see in the picture, that is a characteristic of granulomatous inflammation. There's white, yellowish, greasy precipitates of inflammatory cell, and it's wedge-shaped at the inferior corneal endothelium. And for the picture below, there is trabecular meshwork nodules, as you can see. And in picture D, there's vitreous opacities, or also called snowballs. Next. Okay, the next key sign is multiple chorioretinal peripheral lesions. And if you look at picture A and B, there's multiple small pale yellow infiltrates. In C, there is multiple large confluent infiltrate. And in D, if you can see that there's these yellowish white spots that are called the retinal granulomas. Next. Okay, the next key sign is nodular and or segmental phlebitis, or also known as the candle wax dripping. As you can see in picture A, that is a perivenous exudate that looks like candle wax dripping. And picture B is occlusive periphlebitis. Next. Okay. And here we can see optic disc nodules or granuloma. In the picture, there is a persistent disc edema, which is a frequent finding in patients with retinal or vitreous involvement. And other key signs that we can look for is like in picture A, there is lacrimal gland infiltration and dry eye. And in B, there is eyelid nodules, or if you can see here, there are small tiny growths at the lower eyelid, which is called the lower lid granulomas. Next. Okay, so proceed with the systemic infections and its ocular manifestations. So first is tuberculosis. So ocular tuberculosis is an extrapulmonary form. So primary infection directly to the eye is quite rare, but secondary ocular TB occurs as a result of hematogenous spread from distant site or direct invasion from adjacent skin, sinus, or cranial cavity, or also as hypersensitivity response to distant infections. So Mycobacterium tuberculosis is an obligate aerobic bacteria which is usually found in highly oxygenated tissue. So which is why TB affects the lungs in 80% of patients, and it can also affect other organs, including the eye, especially at the choroid, because the choroid has one of the highest oxygen tension in the body. Next. So as for the pathogenesis, like I said, TB is caused by Mycobacterium, which is an obligate aerobic, slow-growing, non-spore forming, and non-motile bacterium. It spreads through airborne and
Okay, skip that. So
okay.
ocular TB manifestation.
So for the ocular TB manifestation, we have 5 types, which are ocular adnexa, anterior segment, posterior segment, neuro-ophthalmic, and drug-related ocular toxicity. Next. So for ocular adnexa manifestation, the first one is lupus vulgaris, which is usually unilateral and insidious in onset. It at first appears painless, soft with reddish brown nodules, and as it progresses, it becomes slowly enlarged, irregularly shaped red plaque, which can ulcerate and cause scarring, which can be painful. It is usually accompanied with lymphadenopathy, as you can refer to the picture. Next is eyelid tuberculous granuloma, which is also unilateral and insidious in onset. It is usually violet brown, non-tender, and mobile nodule. This nodule can also ulcerate, and it can be very painful and can also produce discharge. Okay, next. For anterior segment manifestation, the first one in the picture is tuberculous conjunctivitis. Then we have conjunctival granuloma, which is a type 4 hypersensitivity reaction, basically, and it presents as an inflammatory mass on the conjunctiva. Then the third one is flictanular keratoconjunctivitis, where it manifests as slightly raised small pinkish white or yellow nodules surrounded by dilated vessels located on the conjunctiva. Then we have tuberculous scleritis, is localized focal elevated nodules of the retina, and usually the sclera may be infected by direct spread from conjunctival or hematogenous spread. Okay, next. For posterior segment manifestation, first we have the choroidal tubercles. This is the most common manifestation of intraocular tuberculosis. So usually people can be infected through hematogenous spread, and choroidal tubercles can be unilateral or bilateral. So usually these tubercles, like you can see in the picture, they appear grayish to yellow in color, and they have distinct borders. And then we have serpiginous-like choroiditis. They are chronic, progressive, recurrent inflammation that primarily involves the choroid and progresses to involve the retina secondarily. And this lesion usually begins at the peripapillary area and spreads centrifugally. And then we have the choroidal tuberculoma as well as the subretinal abscess. Next. Okay, next is AIDS. So for AIDS, we know AIDS is caused by infection with HIV virus, and usually for ophthalmic manifestation is usually at the lid, anterior segment, orbit, retinal, and neuro-ophthalmic. So ophthalmic problems in AIDS are actually very common, and they range from mild conjunctivitis, or they can be sight-threatening retinitis, and any ocular or orbital tissue can be involved. Next. So for the leads or conjunctiva, there are several manifestations that can happen. The first is trichomegaly, molluscum contagiosum on eyelids, you can see in the picture. HIV-related conjunctivitis, HIV conjunctival microvasculopathy, Kaposi sarcoma, you can see in the picture there, there's a Kaposi sarcoma at the lower eyelid, conjunctival granulomas, squamous cell carcinoma, which is associated with human papilloma virus infection, and also herpes zoster ophthalmicus. Next. And then this is a picture of Kaposi sarcoma at the right eye is affecting the eyelid, and at the left eye is affected, the conjunctiva is affected. Then down is a conjunctival granuloma, a picture of conjunctival granuloma. As you can see, there are small tiny growths as at the lower lid conjunctiva. And the picture at the right is how a squamous cell carcinoma looks like. Next. Then for retinal disease, we have HIV retinopathy and HIV-related retinochoroiditis. The picture at the right side is a picture of HIV retinopathy, and the characteristics of the picture, we can see there's cotton wool spots, retinal hemorrhages, microaneurysm, and ischemic maculopathy. And then neuro-ophthalmic disorders in HIV, there can be optic disc swelling, papilloedema, progressive multifocal leukoencephalopathy, optic atropathy secondary to retinal disease, visual field defects, cranial nerve palsies, and unilateral facial palsy. For drug-related ocular toxicity in HIV patients, these drugs, they can cause ocular toxicity and manifest into different types of presentations, such as intraocular inflammation, uveitis and intraocular hypotony, and then corneal lipidosis and vortex keratopathy. So different drugs have can cause different types of ocular toxicity. Next. Okay, the last one is results from the infection with the symptoms of a person with ocular toxoplasmosis is they would usually complain of floaters and blurring of vision. And the signs of someone having ocular toxoplasmosis is necrotizing retinochoroiditis, satellite lesion adjacent to old hyperpigmented scars, vitreous inflammation, anterior uveitis, and retinal vasculitis is also present occasionally. So the picture there shows an image of how ocular toxoplasmosis looks like. Next. Okay, that is all from me. Thank you.
So next, I will present on malignant disorders. For this topic, I will focus on leukemia. Next. So for brief introduction, leukemia is malignancy of the hematopoietic stem cell involving abnormal proliferation of white blood cell. There are four major types of leukemia, which are ALL, AML, CLL, and CML. Both acute and chronic leukemia can cause ocular manifestation. Next. Ocular complication of leukemia can be either direct or indirect. For direct, it is occurred due to infiltration of the orbit, iris, choroid, optic nerve, and other tissues by leukemic tumor cell. For indirect, it can be caused by the first one is the hematological abnormalities such as anemia and thrombocytopenia that can lead to intraretinal hemorrhages, white center retinal hemorrhages, cortical wound spot, macular hemorrhages, hyaloid hemorrhages, and vitreous hemorrhages. And then it also can be caused by CNS involvement through the infiltration of the optic nerve that causing papular edema due to high intracranial pressure and cranial palsy. And also it can be due to opportunistic infection, and the last one can be due to chemotherapy related. For example, if a patient had high dose of glucocorticoid, it can cause ocular hypertension, cataract, diplopia, and various other disorders. Okay, next. So for fundus changes in leukemic patient, it can be retinal hemorrhages, cortical wound spot, which are the retinal hemorrhages with white center, and peripheral retinal neovascularization, which is an occasional feature for chronic myeloid leukemia. Okay, next. So for the retinal hemorrhages in leukemia, picture A shows that numerous flame hemorrhages with potent wound spot and red spot. Picture B shows the premacular bleed, and the last picture shows the large retrohyalite hemorrhage. That's for the retinal hemorrhage in leukemia. Next. So first picture shows the peripheral retinal neovascularization in chronic myeloid leukemia. For neurovascularization, it was recognized that angiogenic factors secreted from the tumor maybe play a role in the pathogenesis of retinal neovascularization. Picture B shows the leukemic chororetinal deposit, and the picture C shows the leopard skin appearance due to choroidal infiltration in chronic leukemia. I think that's all from us.
Okay. End of the presentation. So, siapa leader untuk presentation ni? Or any presenter lah. So what is the take-home message for this presentation? Atau ada apa dia punya significance of this lecture? especially on this topic?
So that whenever we saw a specific sign, we
Apa dia?
can think of. So that when we saw a specific sign, then we can think of other systemic condition for that patient.
When we find when we find a sign, we can think of a bukan other specific, bukan other systemic condition. Maknanya dia ada dua scenario. Okay. But the underlying principle is that some systemic diseases have ocular manifestation. Okay. So which brings about to the possible scenario, which is one, the patient is being referred to you with an underlying systemic disease. Okay. Contoh paling mudah ialah diabetic. Patient is referred to you from the diabetic clinic. Okay, so bila patient sampai di eye clinic, you know what to look for. Okay, you know what to look for, you know what to see, and you need to ascertain the punya condition. The second scenario is that the patient comes to you with an eye condition. He or she is not aware that they have a systemic disease. Okay, what they know is they have an eye condition, and when you see in the eye, you see, ini macam typical of diabetic retinopathy. Alright, and that's when you have to refer the patient to your diabetic or to your medical colleague in view of to rule out patient having diabetes mellitus. Okay? Faham?
Doctor.
Alright. Any other questions before we end our session today?
I think no, doctor.
Okay, kalau macam tu tak apa. Thank you very much. Have a nice day.
Doctor.
Thank you, doctor.
Thank you so much, doctor.
Thank you, doctor.